So I called it Wake Up Stroke because we wanted you to wake up, but actually this is not about wake up stroke, which is people who have their stroke after they wake up in the morning, or that's when we discover them. This is basically a themeless collection of cases just to pin on maybe different things in the clinical practice, that questions that you might have come across, and to kind of get you thinking about the decision tree. So this is our fourth conference. I'm going to just briefly recap some of the data that we've already covered in many of the previous conferences, and we won't spend a lot of time on going over all of those trials, but what we had talked about a few years ago is that beginning in 2013 and 14, there was a publication around the same period of time of many, many trials that showed that there was a great deal of benefit for endovascular stroke therapy. And to summarize very succinctly, what they all said is that when you have a large vessel occlusion, within 6 hours doing a procedure to try to extract that clot or open up the blood vessel through a transcatheter-based therapy would drastically improve the patient's outcome. And this is a list of those trials. And then following that, more recently in the past year or so, there was 2 more trials that even expanded the time window that that same type of treatment could be beneficial for people even going out to farther time periods, 18 or 24 hours. But in those cases, you need more imaging. And so again, just to define what is an intracranial large vessel occlusion. So sometimes you might see on CAT scans the term lacunar stroke. That is a very small blood vessel that's an arterial that is beyond the resolution of what you can see on imaging. So when we talk about large vessel occlusion, it's something you can see first of all on your CT angiogram or your MR angiogram, and it would be the intracranial internal carotid artery, the middle cerebral artery, probably up until its second branching point. The basilar artery technically is a large vessel. It actually was a minority of the strokes included in these various trials. The workup that you need at the very basic imaging is a non-contrast head CT, and you're really looking for nothing. You want that study to be negative. You don't want to see a hemorrhage, of course. You don't want to see a large stroke. Sometimes when you start getting into the later time windows, you can't rely on the CT by itself. You need penumbral imaging or core infarct imaging to be more reliable that there is no stroke even if the non-contrast head CT is negative. And an important point, it doesn't mean that when you do endovascular therapy, you are excluding the patient from TPA. These treatments are given together. And finally, just to recap, there is a grading system that we use to grade a CAT scan. I won't go over it in great detail other than just to say that it starts with a score of 10, which is a normal CAT scan. And when you start to take away 1 point for every abnormal area, once you start getting into a score of 5, that's a pretty large stroke that you're seeing on the CAT scan. So that is a recap of what we've already talked about, and now we're just going to go directly into some cases that kind of rely on your clinical decision making. To do that, you have to first recognize a stroke. Sometimes that's easier said than done. You have to be aware what is the treatment strategy, and then you have to identify what's really the risk-benefit ratio for every treatment and every pathway for every patient. Every patient is different. So this is a first example. This is a 76-year-old woman with a history of atrial fibrillation who is on one of the novel anticoagulants and who actually was on her way to her cardiologist office for a routine appointment. Nothing to do with stroke, probably something to do with their AFib. And she noticed when she was getting off the elevator, she just kept dropping her pills. She didn't seem quite right. She got into the waiting area of the doctor's office. Same thing kept happening, but she was able to check in. I mean, she walked all the way from the parking lot to the doctor's office inside. And so it was really, I think, a lot of credit primarily goes to the cardiologist, who knew this patient very well and who knew that this is a woman who is highly functionally independent by herself and doesn't typically come in dropping pills. And the reason she's dropping pills is she can't see or she's not aware of the pills that she's actually holding in her left hand. And so he just sent her straight away to the hospital, and the patient came to our emergency room. So she had an NIH, which I am sure many of the other speakers have mentioned that. You all are familiar with that. That's our bedside clinical test to gauge stroke deficit. So she had a score of 4, which is relatively low. She had some mild neglect, some slurred speech, and then this was her CT angiogram. So you see that this is on the right side. You see how the contrast peters out over here in comparison with the left side, where you see a very dense contrast filling the MCA bifurcations. And so this was read as a distal right middle cerebral artery occlusion. Now, this is our decision-making tree. So what are we going to do for this patient? She is on a novel anticoagulant. So she is unfortunately not able to get IV TPA. Her last dose was the previous day. She dropped the dose today. That was one of the pills that she dropped. But otherwise, she's ineligible for IV TPA. So we see this large vessel occlusion on angiography. I showed you all those 5 trials, and we went over them the past 3 years that show that there's a lot of benefit to doing thrombectomy. It's our only option for recanalization. On the other hand, you have somebody who's fairly functional right now. She has an NIH stroke scale of just 4. There are inherent risks of thrombectomy. There's a 6% risk of symptomatic intracranial hemorrhage, which in the worst case scenario could be fatal. There could be other risks that go along with the procedure, such as an access site hemorrhage. She could develop femoral bleeding. She might have a severe contrast allergy. She already got contrast for the CT angiogram, and now we'll have to give her more contrast for the thrombectomy procedure. What if she goes into renal failure? So that's the decision-making that happens when you see a patient like this. It's not that difficult, and I'm not going to necessarily show you easy cases when somebody has a left middle cerebral artery occlusion and they're globally aphasic and densely weak on the right side. I think that you can very easily stratify the risk-benefit ratio. The risk to the patient of not doing anything is very, very high compared with the 6% risk of the procedure. But here, what you're saying is we don't have a crystal ball to see the future. We don't know what's going to happen to this patient if we leave her alone or not. So what else could help us? So in this case, we don't necessarily have to get perfusion imaging. The patient came in relatively soon within the time frame of her symptom onset. But because her NIH stroke scale was very low, we want to get some other imaging that will maybe help to tilt the scale one way or the other. So we have non-dominant hemispheric infarction, meaning it's not on the part of the brain that controls language. And one of the pitfalls of the NIH stroke scale, although it's a very good, reliable measure and it's very easy to train people, and many people can do it across different specialties, many of the points are attributed to language deficit. So if you have somebody who has a stroke that's not in the language area, there are not that many questions or examination points on the NIH stroke scale to try to elicit an abnormality. So those patients by default will never, the same occlusion on the right side is not going to have the same type of a stroke as that mirror occlusion on the left side. So here what we can do is we can get some penumbral imaging. Maybe more imaging will tilt the scales a little bit. And so here when we look at the patient's CT perfusion and the transit time, the time it takes for all the blood to get there, you can see that there's this huge delay on the right hemisphere of the brain, how it's more red on this side as compared to that side. And what they say is that the part of the brain which is so-called hypoperfused, meaning doesn't have the same blood flow that it should, but not so severe that it's irreversibly infarcted, that is about 80 milliliters compared to about 1 milliliter, or maybe there's some irreversible infarction. So this is what we're talking about with core infarct imaging and penumbral imaging. So another way of looking at this CT is you're trying to use this perfusion CT as your crystal ball. You're trying to predict what will happen to the patient down the road. What is going to be the fate of that territory that was supplied by that blood vessel that had that blockage in it? What else is going to be suffering and what might go on to infarct? And so the question is, could all of this infarct? And so in this patient's case, we did take her to angiogram, and this is what we saw. And to be perfectly honest, this is probably something that may have been exquisitely sensitive to IV TPA had she been amenable. What you see is you see a difference in the contrast density in the middle cerebral artery in the region of the MCA bifurcation. You see how there is white and black. It shows that there is some lacing of the contrast at the wall periphery, but there's some intraluminal filling defect where there's clot. Seeing that type of appearance probably is something that could have opened up with TPA had she been a candidate, but unfortunately she was not. And so once she is revascularized, you see the clear difference that this is what's at stake, this vast amount of brain tissue that you don't see any of these distal branches without that blood vessel being open. That's what's at stake. And so in this case, the treatment strategy was, one, once the stroke was recognized by her primary doctor, sent her in, knowing that we couldn't recanalize the blood vessel any other way. We opted for a recanalization strategy, and then the other question down the road was secondary prevention and looking at the most appropriate type of agent for her to prevent another stroke from happening. So here's another patient, a little bit more difficult to kind of risk stratify. This is a very young man, 41 years old, with diabetes, and this is his third emergency room visit in the space of 2 weeks. And he keeps coming back with left-sided numbness and left-sided neglect. Now, it stands to reason that if he's gone home every single one of these times, these are mild symptoms. It's not a very severe neglect or weakness that the patient wasn't able to be discharged back to his previous way of living. But in all of these visits, this is what he's accrued. He's accrued this sort of subcortical ischemia that we see in the right frontal periventricular lesion. And this is his CT angiogram, which on the face of it, it doesn't look that significant. You do see a blood vessel going in the right side that's open, but there is definitely a difference in the caliber between the left side and the right side. You can appreciate how the left side, where the arrow is right now, is much fatter on the CT angiogram as compared to the right side. And so let's look at all the data that we got on all these 3 visits. So 11 days ago was his first ER visit, so he came in with those same symptoms. His CT in the emergency room was negative. His CT angiogram was also negative. In retrospect, perhaps it actually showed some stenosis. I don't have that picture up here for you. And then he was admitted for a stroke workup, and they did an MRI, and they saw some right frontal stroke, which ultimately corresponds to what I showed you on the current CAT scan. And so this is a patient who was essentially naive to any secondary prevention. This was his first ever stroke. So from that point on, he was put on aspirin. Then 4 days later, or a week prior to the current admission, he came back. So he came back with a recurrence of the same symptoms that seem to have gotten worse. This time the CTA is read as having a high-grade stenosis of the MCA, and that in retrospect, it was actually seen on the initial CAT scan, but just not called as such. There's no great change between those 2 CT angiograms. And when the MRI was done, there was no new areas of stroke, just whatever they saw on the previous visit a few days prior. And so now the treatment is to add Plavix. So he's on Plavix and aspirin, dual antiplatelet therapy, and the secondary prevention strategies to try to reduce his risks, such as diabetes management. So now he comes back on the day of the visit. So this is about a week later from that one. And he has a CT that I just showed you with that frontal lucency. And he has the CTA reading high-grade stenosis of the right ICA and the MCA. And he has this perfusion that shows that there is this prolonged transit time delay, and the area that's very, very dark red on the blood flow map corresponds to the core infarct. It very well correlates to what we see on the CT. So the other way of saying it that is that this red part over here is probably the irreversibly infarcted area, and this orange or yellowish area is the tissue at risk. So now what do we do with this patient? He's already on aspirin Plavix and he keeps coming back. He doesn't have a frank occlusion, but he's had recurrent symptoms. So there was actually a trial a few years ago that was looking at intracranial stenosis. And ultimately they found, to the surprise of the trialists, that medical management turned out to be quite effective as compared with intracranial stenting. But there were some people that tended to be the high-risk groups, and those were the people that tended to be probably the ones who would have benefited from stenting more. And those were people who returned with symptoms in the first 30 days. And so this patient, who is essentially failing maximal medical therapy, dual antiplatelets, recurrent visits within the first 30 days, is an exquisitely high-risk patient, very, very high risk for ongoing stroke. So in his case, we have a similar situation to the first patient, however, and that his symptoms are relatively mild. Although he keeps coming back, although we see abnormality on the MRI and the CT, his NIH stroke scale is about a 4, maybe even less, with just mild numbness, mild weakness, mild neglect. And again, this is not on the language part of the brain, so perhaps the same situation flipped in reverse would have been much more serious had it been on the left side. And the other thing to consider is the time frame. Not only is he outside of 24 hours, he's pretty much within the 11-day time frame from going back to when this patient was ever first normal. So this is a very difficult decision. You could definitely do a lot of harm by trying to be aggressive and opening up the blood vessel. At the same time, I showed you that perfusion, which we're using as our poor man's crystal ball, that might show you what the fate of this territory is if it's left unperfused. And by no means am I up here trying to say that what we did in this case is the only answer. There is multiple answers to this case. What we're just trying to get you to do is think a little bit and maybe follow the reasoning of the clinical stroke team, because this is the process that we go through when we're seeing these patients, and we might not do the same thing in a different day with a different patient for a different reason. So obviously by the study I'm showing you, we took the patient to angiogram to at least get more information. So what you have on this side of the screen, the left side of the screen, this is a picture of the right internal carotid artery injection, and this is the left internal carotid artery injection. So let's look at the left internal carotid artery injection. You do see the nice left anterior circulation filling very, very well. And you faintly see that there is some mechanism of collateral circulation going towards the right side. And although it's very shadowy, very hard to see, the vessels do appear patent, which would correlate with what we saw on the CT angiogram, that there is a patent vessel. But this vessel, if this was the mechanism that this patient is going to fill that right middle cerebral artery for the rest of his life, such is the case when a patient has a chronic internal carotid artery occlusion in their neck, you might see a picture where the right ICA fills to exactly the same timing and degree of density as the left side. So this is showing you angiographic evidence of transit time delay. By the time the contrast reaches the capillary phase on the left side, you're barely getting to the M2, M3 segment on the right side. That is the meaning of flow failure. And flow failure is a function of time. That day 1, day 2, the compensatory mechanisms are kicking in, all the blood vessels are maximally vasodilated, but it doesn't take much. It takes a drop in the blood pressure, it takes fatigue of those blood vessels over time for that system to ultimately fail. And so this is what we did. We actually were lucky in some respects that we didn't have to entertain more aggressive options such as implanting stent material in there. This patient actually recanalized with the thrombectomy. It is not a perfectly healthy vessel. There may be still some stenosis right at the bifurcation, but it was a sustained opening that we watched on angiogram for about 40 minutes, and we could feel comfortable that the vessel was going to stay open. But going forward, you have the secondary prevention kind of issues of how best to prevent this from happening. Dual antiplatelet therapy is probably the strategy most people would employ in this case. He doesn't have atrial fibrillation. He really doesn't have any reason to put him on anticoagulation. We're hoping that now that we've removed that clot burden, aspirin and Plavix can do their job and prevent added clot on top of it. So this is a 24-year-old man, and I basically just put the consult straight from the hospital record because to show you how difficult this case was. So 24-year-old man with no prior past medical history presents due to headache. Per mother and sister, patient has been having sinus problems for 4 months and a sore throat. He was found negative for strep, but got penicillin, which he completed a week and a half ago. Sunday morning, he had nausea, vomiting, fever, headache. So when you hear nausea, vomiting, fever, headache in a 24-year-old, you are not thinking of a stroke. You're probably thinking of meningitis. He tried to go to the bathroom, but he couldn't get up. He complained of no feeling on the left side of his body, weakness and tingling. He couldn't speak, flopped around, and his eyes were not focusing. All right, so maybe this is a very bad case of meningitis, but you might still be thinking of meningitis. You might be thinking that the patient is just so sick that his consciousness is impaired, and that's why he's flopping around and unable to focus, etc. However, the focal symptoms, this is the thing that should start ringing the bells in your mind, that the meningitis wouldn't necessarily have that degree of focality to it, left side of the body symptoms. So that's where you have to start widening your workup a little bit. So he came into the hospital by emergency room. Now, what's not mentioned in this one paragraph, but later in the chart I didn't put up here, is the patient actually had gone to another hospital prior to this. He'd gone to an area hospital a few days earlier with not so much the eyes not focusing, etc., but the headache, the nausea, vomiting, and the left-sided symptoms. And they did an MRI there, and the MRI was negative. And because nobody's thinking of a 24-year-old patient to have a stroke, no vascular imaging was done. And actually, it was there that the patient received the treatment with the penicillin. So now he comes in, the situation has gone from bad to worse. He has decerebrate posturing, he's comatose, and he's intubated in the emergency room. So this is what happened. So here I just recap what happened at the other hospital. Here in our hospital, they do a CT scan. The CT scan doesn't show anything. A lumbar puncture is performed. That wasn't done at the other hospital. Very appropriate. You're thinking of meningitis, do a lumbar puncture. The lumbar puncture comes back negative. Everybody's scratching their head. So they send the patient back for a CT angiogram, and it shows a basilar artery occlusion. Nobody was expecting this, but this is so important, and the gravity of this situation is so severe. That is why everywhere in the hospital those signs are plastered about be fast. All those DDDs, those words for not missing posterior circulation stroke, because this is the consequence, direct coma. So this is what you see over here. You see that the contrast is going up, this is a coronal view, and then all of a sudden it kind of stops. And why you see these branches at the top is because there are collateral pathways from the anterior circulation filling the posterior communicating artery. And it is for this reason alone that the patient didn't present in coma 4 days ago and he's only presenting now. It's because that top of the Circle of Willis is doing its best, trying to hang on. He's trying to hang on by all those circulation, those collateral mechanisms. But what I say, it's a function of time. Flow failure happens over time. The system is fatigued, and that's when he goes into coma. So this was his diffusion MRI, a lot of stroke. And almost the entirety of the pons at this level is infarcted. This was his MRI on the level of the cerebellum, and you can see that there's a very bright lesion in the left cerebellar hemisphere. And if you look, they don't look bright to the same level, right? You'll agree that on the right side, the pons looks not so bright as the left side of the screen, because that one is older. That's what took him to the emergency room a few days ago, and this is probably more recent ischemia. So this is a very difficult case. What do you do here? Actually, Grace, this was your patient. So this was the question of, do we try to go in there and open up this patient's blood vessel? Do we have any other option for recanalization? Would we give TPA to this patient? Probably not. He's definitely outside of any time window in any trial that I've ever seen with a lot of infarction. And there really is no other option. However, he is not a 24. This is not a dawn or diffuse patient. This patient is outside of 24 hours, and there is widespread pontine ischemia. And again, like I said, I'm not standing up here to tell you that what we did is the right answer and you should do this every time. Things could have gone a different way. Perhaps because of his young age, but perhaps because we had little to lose. You know, when we talk about risk-benefit, 6% risk of a procedure probably isn't worse than coma, sustained coma. And so because he was so grave and had already probably gotten to the worst of what he could do aside from just expiring, we felt that we would go ahead and try to offer him treatment. So this was his initial image. This is a right vertebral artery injection, and you can see what I showed you on the CT angiogram, that level where the contrast stops, that's where the basilar occlusion is. Now, because the CT angiogram is giving contrast in the vein and it's going everywhere, you see all the blood vessels filling at the same time. This is a selective injection, so we're not going to see those collateral vessels on the top, the PCOMs coming from the anterior circulation filling in, but they are there. So you're missing many of those pontine perforators that go from this level, the middle of the pons, all the way to the pontine apex. And you're probably missing small perforators to the thalamus. And the thalamus is a very important relay station in the brain. And when you have bilateral involvement, patients can get comatose. And so this was his angiogram after thrombectomy. With relative ease, it opened up. But that's not really the important point. Now, the important point we see after thrombectomy, which we could kind of see on the pre-thrombectomy run, is this is a little bit of reflux into his left vertebral artery. And there is a big difference between the left vertebral artery and the right vertebral artery. The vertebral arteries join together to form the basilar artery in kind of the shape of an upside-down Y. It's very uncommon that we have two vertebral arteries that are exactly the same size. Usually one is big, one is small. One is dominant, one is non-dominant. So in this patient's case, his therapy was offered through the non-dominant vessel, but you can see that this is a dominant vessel with such a big difference. And so we have to see what's going on with that vessel. And this is actually what the problem with this patient is this left vertebral artery should pretty much be this thickness from top to bottom, from bottom to top, I should say. But instead, we see this flow gap, almost all of the V2 segments. So the problem started here and probably through a clot to the patient's brain. And so we did do a thrombectomy over here. And now you can see that we've got a channel of blood flow going, but it's still a very, very abnormal vessel. Some of that ribbing or undulated appearance is possibly technical spasm. The vessel easily will spasm in relation to introducing any wires. But there are definite areas where there is some stenosis here. And this was kind of just as more time went on, this is how it looked. Maybe this patient has an underlying collagen vascular disease, fibromuscular dysplasia, that perhaps predisposed him to having a dissection at that vertebral segment. We don't know. But there is still patent flow into the brain. And so this was his 48-hour MRI scan. So the basilar artery is open, and you can see probably better on this study than on the angiogram, the difference in the vertebral arteries. The left side is the dominant vessel. And this now, much of what I showed you, that kind of spasm has resolved. That was probably just a dynamic process initially, but you're left with this area of very fixed stenosis right here. So this patient was put on dual antiplatelet therapy, so luckily for the patient, he actually made a decent outcome. He woke up from his coma. I never in my life would have imagined I could see a pons that looks like that on MRI, and the patient will wake up. Maybe because he was a young patient, and maybe because it wasn't like that for weeks and days. It was a matter of a few days rather than a few weeks. So at 6 months, he is ambulating, he's walking, independent of most of his ADLs, but he does have an ataxic hemiparesis of his left side, and he's planning to return to work this month. And so this is his follow-up imaging by MRA. So that focal stenosis I showed you, that is now gone. But what you see is you see this little divot right over here, which is a little pseudoaneurysm that's developed. So a pseudoaneurysm is different from a true aneurysm in that it doesn't involve all the layers of the blood vessel wall. A blood vessel has an adventitia, a muscular layer, and an intimal layer. And so what's happening in the case of a dissection with a pseudoaneurysm is that blood is invaginating in between those layers. And so there's intramural blood compressing the lumen of the blood vessel. So what to do about this? Do we leave it alone? Could this be another thrombotic source of stroke? It certainly could. Perhaps we try to go in there and tack it down with a stent or with a flow diverter. And so this is some of the treatment strategies for this patient. Medical management, there's no procedural risk, of course. There's the risk of not knowing what's going to happen to that lesion over time. Will it get bigger? Will it cause another stroke? The endovascular risk is all the risks of the procedure and the necessity of having to keep him on double antiplatelet agents for a longer period of time. So I mentioned the word flow diverter. I'm going to segue a little bit just to talking about this real quick. So I think you all are probably aware of what a stent is. Stents are used in the coronary vessels and other vessels. For lack of a better term, a flow diverter is like a stent, but it is not a stent. I guess you could say it is a cross between a stent and an endograft. So it's a very tightly woven mesh material with the aim of trying to form place a scaffold for normal endothelialization of the blood vessel to occur. And so this is just a sketch of an aneurysm. And so what causes aneurysm, and this would probably be a model of a true aneurysm, not a pseudoaneurysm, but there's a weakness in the blood vessel wall, and that bulges. And over time, day by day, minute by minute, blood is coursing in that blood vessel along that point of weakness. It stretches it out, causes this blister, causes this aneurysm. And being that the whole thing came about in the first place from a point of weakness, the vessel wall of the aneurysm can give way because it too is weak. And so there are two schools of thought on treating aneurysms, which I'll go into in the next couple of slides. But the concept of the flow diverter is to offer remodeling at that point where the weakness first occurred, at the neck of the aneurysm. And so now we'll leave stroke for a minute and show you some aneurysm cases and try to explain why we sometimes use flow diverters or whatnot. So this is a 66-year-old woman who presented with headache, and she has a very, very strong family history of familial intracranial aneurysms and subarachnoid hemorrhage. And so when she has headache, they do an MRA, and we see this ophthalmic carotid aneurysm with the measurements showing that in its long axis, it's a little bit over 11 millimeters by about 5 millimeters wide. So the treatment options in this patient might be observation, don't do anything, it's unruptured, and you have to weigh what's the risk of this patient to have a hemorrhage. Not every patient with an aneurysm will go on to bleed. We'll go into that a little bit. Or you can repair it, and by repairing it, you can either clip it surgically or you have a variety of endovascular means. You have intrasaccular means, which is when we coil an aneurysm and we treat the sac of the aneurysm, a vessel reconstruction with a stent, like what is shown in this picture, or endoluminal, which is, in a manner of speaking, vessel reconstruction, but it's like using that flow diverter to heal the hole, so to speak. So in terms of the natural history, there were a couple of studies, one of them, which is actually rather old, probably about 20 years or so now, the international study of unruptured intracranial aneurysms. And to summarize very briefly, what they found was that there were two kinds of patients, a patient who might have suffered a subarachnoid hemorrhage from a different aneurysm and somebody who'd never had a subarachnoid hemorrhage. And so the people who had suffered a subarachnoid hemorrhage, if you found other aneurysms in them, those aneurysms might tend to bleed even at smaller sizes as compared to a patient like this patient I showed you who'd never had a hemorrhage before. But then there were also correlations to size. So certain size cutoffs seem to be more higher risk for rupture. And so in the anterior circulation, which is that picture I showed you, the carotid, 7 millimeters seem to be the size cutoff, whereas in the posterior circulation or the posterior communicating artery, 5 millimeters seem to be the size cutoff. And then these studies were somewhat duplicated by newer studies. There is a score tool that we call the PHASA score, and I do this on all my aneurysm patients. And it assigns points to certain things. There are certain high-risk features such as race. Japanese people, Finnish people, actually more high risk. Size, prior subarachnoid hemorrhage, and location. And then there were trials comparing treatments, surgery versus endovascular. And this trial was looking at subarachnoid hemorrhage patients with ruptured aneurysms, and found that there was overall less morbidity with coiling as compared with clipping. But coiling has its pitfalls. The coils can come back together over time, and that can allow more space in the aneurysm to open up over time and to have recanalization. And so in this patient, with this size, 11 millimeters, the larger you get, the more likely you're going to have coil compaction over time with recanalization. Here is where trying to get to the root of the problem, the flow diverter might be a very good treatment strategy, which the drawback of a flow diverter is that it works over time. Rather than compacting over time, it works over time. When you're done with the procedure, the aneurysm might still look exactly the same as before treatment. It's the 6-month follow-up, the 12-month follow-up that you start to see diversion of blood flow away from the aneurysm, and that's when you get the occlusion. So it's not an immediate treatment strategy. This patient, where it's unruptured, she has a family history, large aneurysm, you have the luxury of time because it's unruptured. You can put the patient on dual antiplatelets and sit there and wait. Yes, flow diversion may be a very good treatment option. But if I show you this same patient and tell you that she has come to the emergency room with the worst headache of her life and her CT shows subarachnoid hemorrhage, flow diversion may not necessarily be the best option for this patient. You want something that will work over time. And so because I know the question had been asked, why do we sometimes use this over coiling, this would be one of the reasons. Now, this is a patient who is 57 years old and was found to have multiple intracranial aneurysms. This is looking at a 3D view, kind of looking at the side. This aneurysm is the anterior communicating artery, and then she has 2 aneurysms from the internal carotid artery. And so actually she had 2 types of treatment. She had coiling of her anterior communicating artery aneurysm, which is this one, and then this oblique projection, you can see the ICA aneurysm, which was treated by placement of a flow diverter across the neck of those aneurysms. So at her 6-month follow-up, you do see occlusion of both the aneurysms, treatment in both of these ways. Perhaps if I magnified this further and looked, I might actually honestly say that the aneurysms treated with the flow diversion actually show better occlusion than the anterior communicating artery aneurysm. But I use this slide to illustrate that these are all tools, and we will use all the tools that we need as appropriate. There's a time and place and a reason for using what we do, and then there are treatment considerations such as the antiplatelet medications. Now, I do want to talk a little bit about what happens when we're coiling an aneurysm. So when you look at this picture, this is how it looks at the end of the procedure when you coil an aneurysm. You saw that big ball, and then the big ball goes away, right? Or I can show you, this is the ACOM aneurysm right here, and this silvery shadow is where the coils are placed, right? Looks like the aneurysm is gone. If you cut out that aneurysm and did a cross-section and you looked at it under a microscope, you would see that what looks like beautiful occlusion on an angiogram is probably just 20 or 25% filling of the aneurysm, meaning that that metal is taking up maybe a quarter or a fifth of the space, and the rest of that space, the aneurysm is actually still filled by blood. So actually how it works, yes, coiling does work by, in a manner of speaking, taking up space in the aneurysm. But what's really happening is that it's a place for intrasaccular thrombosis to occur. And so this was an animal model paper, and what they did was they created aneurysms, they treated them, and then they studied them histologically later on. And so what you can see is all that clot material developing on the coil matrix inside the aneurysm. So when I say intrasaccular treatment, that's what we're talking about. We're causing thrombosis in the sac of the aneurysm. But actually, more importantly, what happens with coiling is that you see in electron microscopy and histography over time is that over the matrix of the coils that's at the neck of the aneurysm, the body will form new endothelial cells. So there's this natural barrier that's happening. The blood vessel is kind of building up over the coil mass. And that's actually how you occlude it from the natural circulation, is this process that also happens over time. And this is just further electron microscopy showing you how now you're starting to see a layer of cells here so that blood can't enter the aneurysm. It's like creating a biological door, if you will. So when they clip an aneurysm, by the way, that barrier would be made outside the lumen of the vessel, correct? Right? A surgeon is placing a clip they would do a craniotomy. They would approach the blood vessel from the outside, not transcatheter, not endovascular. And so the separation of the aneurysm from the parent vessel is by placing a clip at the neck of the aneurysm. And so the same concept, excluding it from the parent vessel, that's what's happening. So we're going to move into left ICA occlusion. So this is a patient, 78-year-old man, with atrial fibrillation who comes in with altered mental status over 8 hours. So this is what we call in our hospital level 2 stroke alert, right? He's not in 6 hours. Level 2 is when it's 6 hours to 24 hours. His non-contrast head CT was unremarkable, meaning aspect 10. We don't see blood, we don't see stroke. His CT angiogram showed essentially absence of the intracranial internal carotid artery and very faint opacification in the region of the MCA bifurcation. Because this is level 2 and we can't rely on the CT scan alone, we need to get more sensitive core infarct imaging. That's why we get perfusion imaging. So in this patient, he has a tremendous Tmax delay on the left hemisphere without significant core infarction. So this is an appropriate candidate for thrombectomy based on all the radiographic and the clinical data. And this was his angiogram. So he has left internal carotid artery injection. You see absence of all these blood vessels. And then once we get the thrombectomy done, you see recanalization of all the blood vessels. This case is not really a decision-making challenge. It's not necessarily a treatment strategy challenge. I think it's more the secondary prevention. So there was mention of what causes stroke. The patient had AFib, but he was on secondary prevention with warfarin. This was his carotid artery. There is narrowing indeed, but when we go by the book and we use what is called the NASCET methodology according to the NASCET trial that was done a few years ago, we are comparing the proximal segment to the distal segment, and it's probably not more than 50% if you use that methodology. And so I don't know if that would really be considered to be symptomatic stenosis. On the other hand, this is a patient who has AFib. Was this an atrial fibrillation-related clot? Should we just switch him from warfarin to a novel anticoagulant, or should he be offered atrial appendage closure? So this is a different case. So the last few cases, actually something I ran out of time last year, which I find very difficult is when we have these extracranial carotid diseases that present acutely. So I'm not talking about somebody who has a minor stroke. We find that they have carotid stenosis, and then we tell them that they need a carotid endarterectomy or stent. It's not that patient. It's the patient who comes like this. Right hemiparesis and aphasic. They look like they have a large vessel occlusion, but when you do the brain imaging and the neck imaging, they don't. This in the middle is the 3D reconstruction, and actually everything looks okay. But when you look in the neck, you see that this patient has this big bite taken out of his common carotid artery with very poor flow to the internal carotid artery. So this is extracranial disease, isolated extracranial disease, although I will say very, very severe clinical presentation. And so this was the initial brain MRI, not too bad. You see a little bit of restricted diffusion, primarily in the temporal lobe, maybe also in the parietal lobe. And so the question is, do we do medical management? It's not internal carotid, which is really where all our data is. It's common carotid. So we don't really have the guidance of literature for this. This would be a very individualized approach to this patient. And if we do some sort of carotid repair, what is it? Is it going to be surgical? Is it going to be stenting? What are the risks? And so I would say maybe about 2 or 3 years ago, the American Stroke Association, they kind of made their guidelines that for internal carotid stenosis, not necessarily this patient, but the timing of intervention is best between 48 hours and the first 2 weeks. So let me say it backwards. If you wait longer than 2 weeks, what might happen is that your patient is very likely to suffer a stroke. And if they don't suffer a stroke, maybe they're just the lucky ones where medicine seems to be working and they probably maybe could have not had the procedure in the first place. On the other hand, if you rush to do it so early because you don't want them to have another stroke, they're in a very sensitive phase. There's a lot of baroreceptors around the carotid artery when they have carotid artery stenting, so we commonly see that the blood pressure will drop. Can an acute stroke patient tolerate that? They're totally dependent on collateral circulation, and so if you drop the blood pressure, you are really stressing that collateral circulation. So maybe the first 48 hours is a time period when it's maybe more prone to having complications such as hypotension-related complications. The other possibility is maybe there is a recently embolized plaque. That's fresh plaque. Maybe adding your statin therapy, adding antiplatelets might stabilize the plaque. And so you wouldn't be doing a procedure when it's very unstable, hyperdynamic, ulcerated plaque. So those may be some of the considerations. We're not doing the procedure too early. What you worry about by waiting is what's going to happen, that crystal ball. You need the crystal ball, right? You don't know how much of that stroke is going to expand from that temporal lobe infarct to something else. And so this was this patient's perfusion CT, which was actually done the next day, but it looked fairly stable. It didn't look actually to be very impaired. So this patient looks like somebody who really doesn't have a lot of perfusion failure, which then kind of goes back to the original question, why is a stroke so bad? The brain blood vessel is open, the collaterals aren't so bad that the perfusion looks bad. So why is this patient not talking and hemiparetic? There are other things. So this is kind of a reminder that the imaging doesn't tell us always the story, right? The imaging can't tell you what's happening at the neuronal level. Maybe if you do an EEG, you'll see left hemispheric slowing on this patient. There is something happening beyond the resolution of imaging on this patient. So we were planning for elective carotid artery stenting on this patient, but we got a brain MRI and follow-up probably the day or so of the procedure, and we do see stroke expansion, not what we wanted, but we also see that there has been some spontaneous reperfusion hemorrhage, which is not uncommon. When you have stroked territory to which the blood flow is reestablished, there's going to be some bleeding because there's inherently a breakdown of the blood-brain barrier. So because of this finding, we withheld from the therapy. We didn't offer him any carotid repair procedure. He actually went on to have a good outcome. This was his final stroke. He did regain some of his function. I'm not saying normal, but he regained some of his function compared to where he was. So I show that patient in contrast to some of the next patients. Why did that patient do well and another patient didn't? So for instance, this gentleman, 78 years old, same situation, left-sided problem. His disease is a little bit higher. That patient's was lower than what we usually see in the common carotid. This patient's it's higher. It's at the level of the carotid just as it enters a skull base. So you're seeing missing of the internal carotid artery there. You can see over here the carotid density in the carotid canal, and you don't see it on the right side. And we're looking at the sagittal view, there's nothing, right? You're missing all the normal brain blood vessels you should see there. Intracranially, though, it looks like he's filling everything. So in this case, you go through all that same treatment strategy. You have somebody, you might make them worse from the procedure. You don't even know if the procedure is the right thing to do or not. But what you really need to know is the Circle of Willis collaterals. And when you talk about the Circle of Willis, it's really not the major vessels that you see, it's the tiny little vessels that we're looking for. These are the VIPs, or the star players in the Circle of Willis, the anterior communicating artery, the bilateral posterior communicating arteries. And most of us don't have all of them. Most of us have an incomplete Circle of Willis. We might have both of our anterior cerebral arteries coming off of one side, and you might have bilateral, what we call fetal PCAs, coming off the internal carotid. So you don't have that flow between the anterior and the posterior circulation, or between the right and the left. So this patient, by seeing the CT angiogram, you wonder that there could be some collateral flow because it's filling so well. If you look on his MRI, you don't see very good collateral flow. And they are getting information in a slightly different way. I'm not a radiologist, and it's probably beyond our scope to talk about how the studies are obtained. But when you're getting a time-of-flight MRI, it's a little bit more dependent on the direction of flow compared to a CT angiogram, where you might see complete backwards filling flow from what we call the PL collaterals. And you see the false appearance of what we call a pseudo-occlusion, because the intracranial occlusion is so severe, and it's like the blood is hitting a wall. There's just backup of blood flow, and it looks like it's an extracranial disease, but really the disease is at the skull base. And so in this patient, no intervention was done. And he had a stroke expansion that I would not have thought would be fatal. It does not look like this is a very severe stroke, but the ongoing culmination of events, maybe not necessarily the stroke directly, but the secondary complications that ensued, the patient ultimately expired. So you might wonder, why did the 51-year-old do so well compared to the 78-year-old? There are many factors. Age is one of them. Perhaps the Circle of Willis collaterals are another one of them. So this is a patient, 51-year-old patient with right hemiparesis and aphasia. He had stroke 3 years ago with opposite left-sided weakness. Now he's coming with right side, so different strokes. He had an old right parietal stroke on the infarction. On the CAT scan, no intracranial occlusion, but you see left ICA occlusion in the neck. So what do we do in this case? So in this patient was a candidate for IV TPA. So first thing they do very appropriately is commence IV Tpa therapy. While the patient's in the emergency room, he is starting to deteriorate. So our initial hope was give him TPA. That is the standard of care treatment. We don't have a large vessel occlusion intracranially, not do any intracranial intervention. But when he started worsening and the CT did not show any changes, meaning that there was no hemorrhage that developed after TPA, it wasn't that the stroke was necessarily suddenly very visible. That's when we opted to take him for angiography. Prior to that, we did do this perfusion that showed a significant mean transit time delay over the left hemisphere. And so this patient, the first thing was to look at his Circle of Willis, and we do that by looking at every other vessel besides the affected vessel. So when you see this right internal carotid, what I would expect, what I would hope in somebody who has a left ICA occlusion is that you would see good cross-filling from right to left, as dense as you see it on the right side, but we don't see that. Okay, well, let's look at the posterior circulation. Maybe the collateral is coming from there. Now what you would expect to see is you would expect to see a big PCOM filling the ICA all over here. So this patient really has an incompetent circle of Willis. And so that's part of the decision-making strategy where we sometimes maybe will opt to do something in these patients. So this was his injection. You could see a very smooth-looking common carotid, and then the bifurcation was clean. His problem was in the neck, which I'll show you. When you get past that level of occlusion, you see very, very poor filling. So the catheter is here in the mid-cervical ICA, and very poor, meager filling. And we already looked at the right side. We looked at the back. So we know that it's not filling any other mechanism. So if this door doesn't open, there's no other door for this patient to get blood flow. So in this case, we did do a thrombectomy. We did try to open up the blood vessel. And I will not tell you that he necessarily had a good outcome. He had a sustained disability and a very large infarct. But this was his treatment strategy. There was no hemorrhage, and there was no worsening of his condition beyond what he already presented with. Now, an interesting educational point as to the etiology of why this happened to him. I told you that he'd had the stroke 3 years earlier on the opposite side. And you see this delicoectatic segment over here, this outpouching and redundancy right outside the skull base. That can happen the same way that dissection can happen. Weaknesses of the collagen tissue, weaknesses of the blood vessel wall, and this outpouching area can be a nidus for thrombotic blood to collect and then float downstream and cause stroke. One treatment strategy for this patient, if he made a more reasonable recovery, may be actually to do a flow diverter here and to let that delicoectatic segment remodel. So, and wrap up some of the take-home points. What I want to show you that sometimes mild symptoms can still be major strokes, and that's why you really have to think of the worst possibility in your differential. It's great if the patient doesn't have a stroke, but what's the harm to rule it out? Penumbral imaging sometimes helps you when the NIH stroke scale is very low or when the clinical syndromes are very mild. And you need all the information you can get. You do need that collateral imaging to tell you, kind of to inform your decision making. So that's all I have. Thank you very much.